Now's the time we've all been waiting for. We're going to bring on Dr. Joyce O'Shaughnessy. Hey, Dr. O, how are you doing?
Hi, April. I'm doing well. How are you doing? I hope things are going well tonight.
It's going amazing. Thanks that you came on a little bit early, and I really appreciate that because we have a lot of questions for you tonight, and we are always so very blessed and
Good,
thankful to have you on the
good,
show, girl. Thank you so
good.
much.
My pleasure.
So, first of all, girl, fill us in. What's the latest in clinical trials these days for triple negative breast cancer?
Well, the big thing in triple negative breast cancer is to incorporate immunotherapy into chemotherapy, both in the metastatic setting as well as in the curative setting, preoperative setting. And so this past year, we've had approval of two of the checkpoint inhibitors, the atezolizumab, otherwise known as Tecentriq, and the pembrolizumab, otherwise known as Keytruda, that are now approved for the first line setting in metastatic triple negative breast cancer and breast cancers that express PD-L1. And so that's basically the Tecentriq is in combination with Abraxane, a chemotherapy called Abraxane, and that combination improves overall survival by about 7 months, median 7 months in the first line setting. And then the Keytruda can be given with the Abraxane or regular Taxol or gemcitabine and carboplatin. And that improves progression-free survival. We don't have the full survival data yet. So that's very good to see that we have, we're bringing immunotherapy into the first line setting for the 40% of women whose triple negative breast cancers express the PD-L1 protein. Even more importantly, of course, is to increase the cure rate in triple negative breast cancer by getting the checkpoint inhibitors into patients with stage 2 and 3 triple negative breast cancer at the time of diagnosis. And there have been 2 completed clinical trials now adding either the Keytruda, the pembrolizumab, or the Tecentriq, the atezolizumab, preoperatively along with chemotherapy. And both of these trials gave they're called checkpoint inhibitors. The Tecentriq and the Keytruda are checkpoint inhibitors. They're immune stimulants, giving it all during the chemotherapy preoperatively, and then versus chemotherapy alone with placebo versus the antibody itself with the chemotherapy. And then the patients go to surgery. And there are 2 primary endpoints of these trials. The first is the pathologic complete response rate. That is the percentage of women who have no cancer left in their breast or their axillary lymph nodes at surgery. And then the second co-primary endpoint is invasive disease-free survival. That is staying cancer-free, 2, 3, 4, 5 years after beginning the chemotherapy. And both of these trials that are the Keynote 522 and the Impassion 031 trials, both of them have completed enrollment, and both of them have shown a substantial increase in the percentage of women who don't have any cancer left at the time of their surgery.
Wow, that's so awesome.
Yeah, so it's definitely an advance. Both, even more importantly, probably show decreased recurrences with the addition of the checkpoint inhibitor proteins to the chemotherapy. The Keynote 522 is a little further along. It's just got longer follow-up, but it's also a much larger trial. It's about 1,200 women compared to around 350 women or so in the Impassion 031 trial. So there's a greater statistical power in the Keynote 522, adding the Keytruda preoperatively. It's not quite yet statistically significant, but it's looking promising. We'll have to wait until later this year. And then the hope is that if it does turn statistically significantly positive, then it will be approved by the FDA and will become the standard of care. In case anybody was watching, the FDA did bring this trial, the Keynote 522 trial, to its Oncologic Drug Advisory Committee. And I was trying to help in that process. And hopefully, the hope was to get an accelerated approval with the Keytruda while we were waiting for the more mature statistical results, from invasive disease-free survival, that is staying cancer-free at year 3, 4, and 5. But unfortunately, the the FDA and the Oncologic Drug Advisory Committee didn't think that the improvement in the pathologic complete response rate, that is no cancer left in the breast or lymph nodes in the entire population, was large enough to lead to the accelerated approval. But it's what was very intriguing to everyone was that the invasive disease-free survival was really trending in the right direction. Now we have to wait and see, but that's really the hope, that there will be fewer recurrences, which of course is the name of the game. So we will wait and see. They're about a little more than 2 years follow-up. By the time you get to 3 years with triple negative breast cancer, that's getting to be a pretty mature result, actually, and you can really look and see who's had fewer recurrences. The other study with the Tecentriq, the Keynote 031, that showed about a 20% improvement in the percentage of women who didn't have any cancer left in their breast and lymph nodes at the time of their surgery. Because it's a much smaller trial, there's fewer women who have had recurrences, and so the statistical power around the invasive disease-free survival is not as great, but yet the improvement in the pathologic complete response rate is pretty good. 20% is really quite a lot. So we will wait and see whether or not perhaps Tecentriq might get an accelerated approval so that could potentially become a standard of care while we're waiting for other trials with Tecentriq in much larger patient populations, to finish up and become mature and see if it should really become, an absolute fully approved standard of care. So there's a lot of movement here with immune therapy in triple negative breast cancer. There's a lot of interest in getting immune therapies into the curative setting. What's nice about these stage 2-3 trials is that the checkpoint inhibitors benefited women in terms of improving the pathologic complete response rate and also decreasing the risk of recurrence, regardless of the PD-L1 status. Whether it was the 40% of cancers that have the PD-L1 protein or the 60% who either have very little or none, the immune stimulants, these antibodies, benefited both groups of patients. So that's really, really promising. So I'm cautiously optimistic that we're going to have, I hope, both of these agents become standard of care in the not too distant future. Maybe later this year we'll have some approvals. So that would be big. That would be huge.
Yeah, and it's so cool. Every year that we talk at the triple negative breast cancer broadcast, you have more and more great news. And just to help everybody understand, when you say standard of care, like when these things come like a standard of care, would that be for anyone with triple negative breast cancer, or would it be at a certain stage of triple negative breast cancer?
In the curative setting, i.e. when women are first diagnosed with triple negative breast cancer, both studies included women with stage 2 and stage 3 disease. So stage 2 breast cancer, the breast cancer is greater than 2 centimeters or have positive lymph nodes that are palpable, that you can feel in the axilla or see on mammogram or see on ultrasound or see on MRI or PET scan. And stage 3 disease, those cancers are generally bigger than 5 centimeters. So women with larger triple negative breast cancers or nodes positive. So in other words, April, women who have some considerable risk of having their breast cancer recur. Stage 1 triple negative breast cancer, those patients do very well. These are smaller cancers. You can't appreciate any lymph nodes positive. And we still recommend treatment with preoperative chemotherapy. But here's the other part of the immune checkpoint story. And this is why it will probably not be utilized in everyone, is that the immune checkpoint inhibitors increase the chances of an autoimmune process coming up where the immune system gets so stimulated by the Tecentriq and by the Keytruda that there's a kind of overstimulation, if you will, and now the woman's immune system can actually inflame and even destroy some of her own tissues, such as her thyroid. About 15% of women will develop hypothyroidism, low thyroid, and we think it's permanent, so she'll need thyroid replacement. About 5% develop too active a thyroid, hyperthyroidism. But again, these can be treated But then there's a very low chance, very low. We're talking, 1 or 2% of having, inflammation of the lungs, inflammation of the colon, inflammation of the liver. These are generally well treated with steroids. And then there's the very, very rare, 1 in 1,000, 1 in 10,000 chance of something very serious, such as encephalitis, inflammation of the brain. In fact, in the Keynote 522 trial, there were 2 deaths. One was from lung inflammation and one was from brain inflammation. So, and these were sort of an autoimmune. The immune system was too stimulated by the agent, not only killing the cancer, but just really revving up the woman's immune system too much. So because there are some risks associated with these checkpoint inhibitors, we would want to utilize them for women who have high-risk breast cancer. In fact, both of the trials showed that women with lymph nodes positive, so they're presenting now with stage 2 or stage 3 disease, but those who had lymph nodes positive, and that's more serious than having no lymph nodes. And that means either you can feel them or you can see them on mammogram or ultrasound or MRI or PET scan. For example, women where the breast cancer has traveled, from the breast to the lymph nodes, those women got a very substantial increase with the checkpoint inhibitors in the chances of having no cancer left in their breast and lymph nodes, the pathologic complete response. Whereas women with lymph nodes negative, they got some benefit too, but it was much more modest. And the question is going to be, is that improvement going to be enough to justify some serious, potentially very serious toxicity? So for sure, we're looking for this advance for our node positive women, who definitely have the highest chance of having, a recurrence of the triple negative breast cancer. So, hopefully first step, hopefully we'll get these approved by the FDA. And then, we'll look at the final data and look at the node negative, look at the node positive, and really see where the greatest benefits are, not only in pathologic complete response, but also in invasive disease-free survival, the chances of staying cancer-free at 3 and 5 years. That's critical, obviously. And look at the node positive, look at the node negative, look at the whole toxicity picture, and really try to talk to the women, about the risks and the benefits for each individual woman. But we really, really hope we have this available as an option for the higher risk patients.
Oh gosh, that'll be so incredible. That's so cool. So it sounds like I think if I could break that down as far as people who are stage 1, it sounds like the current treatment that we have available, the adriamycin, Cytoxan, Taxol, is pretty effective for the stage 1 folks, and then the triple negative stage 2 and 3, that's where this really comes into play. And Dr. O, I was going to slide this into a question that we had. The previous guest, Courtney Phillips Long, she had triple negative stage 2B. She did a clinical trial that was a PARP inhibitor. And she was curious. We actually, all of us were like, I don't really remember what that means. What is the B part of stage 2B?
I think it's lymph nodes involved. I think it's interesting with staging. It's utilized, I think, tumor registries, et cetera. But it's interesting. The clinical trials and what we do in practice is we ask the question, lymph nodes positive or negative, and we ask the question about tumor size. And so when so we basically say any stage 2, any stage 3 patients are eligible, but the staging has changed relatively recently, and so staging is not as important as it once was. So we basically go: is it nodes positive? Is it nodes negative? And size of cancer. Is it over 2 centimeters? Is it over 5 centimeters?
Gotcha. Yeah.
So that's pretty much how we think of it, because there's so many nuances now. There's so many different subcategories of staging that you really need these. There are computer algorithms in everyone's electronic medical record. You just put in the the key parameters, and then the computer tells you what the stage is.
Wow, that's interesting. And I remember when I was first diagnosed that I went to the American Cancer Society's website and they had like the total breakdown. It was like, whoa, it's so much information. And forgive me in advance, we have a lot of questions for you tonight, and I want to try to cover as many as I can. And it was important to me to have our guests that were on the show submit some questions for you because they donated their time and their stories to this broadcast tonight. So I want to be sure and cover a couple of their questions. I'm going to jump over to Jennifer. Jennifer is going to be on our show a little later tonight. She said that she and her husband watched a dissertation by a doctor or a professor saying that the polio vaccination contained a virus called SV40 that originated in primates, and have come to find out a lot of cancer cases have come from that vaccine. Have you ever heard anything about this? She was asking.
No, I'm very familiar with SV40 viral virus. It's very much utilized in laboratories as part of cancer models because I think it causes sarcoma. It can cause sarcoma in animals. I believe it's sarcoma. It's a very powerful virus, that can cause cancer. So it's a useful tool in the laboratory. But I've never heard of SV40, contaminating a polio vaccine. So I've not heard that. I have not heard that people that were vaccinated with the polio vaccine, which, of course, is, basically all of us. I've not heard that, there's been, an enrichment in breast cancer cases, triple negative breast cancer cases, with increasing vaccination over the decades, for example. So I have not heard that at all. And I do know this, that when we are giving biologic products to patients, and there's many biologic products that we give, there's huge FDA guidelines that have to be checked to look for what we call adventitious organisms. These are contaminants, but they can be biologic living, whether it be bacteria, whether it be viruses, whether it be fungi. These are adventitious agents. And there's a very rigorous process to make sure that these whatever biologic agent it is, and vaccines fall into that category, are pure, are not contaminated with these organisms. And so this is a very, very rigorous process. And so, I don't obviously know when the polio vaccine, first came out. I don't know what was that, the 40s or the 50s. I don't know. I wasn't really, of course, conscious at that point. But certainly, in my lifetime, I've not heard of any concerns around the polio vaccine.
That's really good to hear. It was news to me about that as well, and but I'm glad we were able to answer that question for Jennifer. She also had a question to ask if you know if there are any new treatments in fruition specifically for triple negative breast cancer besides the recent vaccine news. And I think you pretty much covered that at the top, where you gave a really great update on that. So I think we actually covered that one. So Jennifer, thank you for your questions, girl. I know Jeannie had a question as well. She said, why is it that everyone considers triple negative breast cancer to be the worst diagnosis you could get?
That's a really good question, because it's really not true. I think triple negative gets this bad reputation for the simple reason that if the cancer becomes metastatic, then the average lifespan is the shortest that we have for the various subtypes of breast cancer. The median survival, so the average survival, if you will, is only around 18 months, which is, horrendously short. There is a group of patients that will even be cured. A very small percentage of patients can be cured of metastatic triple negative breast cancer. But unlike estrogen receptor positive breast cancer, where at 5 years, half of the women are still alive, maybe 60%. At 10 years, still a third will be alive. At 20 years, you'll still have 10 to 20% alive. The numbers are not nearly as good for metastatic triple negative breast cancer. But in terms of what percentage of triple negative breast cancer patients who present with early triple negative breast cancer, stage 1, stage 2, stage 3, what percentage are cured? I would say at this point, we may be up to 75%. I have been saying
That's amazing.
70% for a long time. And that's not that different from ER positive, HER2 negative breast cancer. The thing about that breast cancer is that it doesn't recur as quickly, and patients don't die as quickly with metastatic disease, but the triple negative gets there faster, but they land up at the same place. So I really think it's because when triple negative becomes metastatic, patients don't live, nearly long enough. Of course, the name of the game is to prevent metastatic triple negative breast cancer, but it's a little bit of a confusion. And women come into me, they're newly diagnosed with triple negative breast cancer. They're scared, super scared because of what they've read. And I've said, oh no, don't worry. You've got one that's highly, highly curable. Don't worry.
We got this. Yeah.
Oh, because they're so scared because of what they read. It's a little bit of a misunderstanding out there.
Yeah, I mean, I've been saying on the show tonight, it's rare and aggressive. It's more rare and aggressive, and I think that's the point that you're making. It is more aggressive when it's metastatic. It's more aggressive, so the timeline gets shortened because it is more aggressive. Correct?
Right,
Yeah.
exactly. Aggressive being very fast growing, basically. And the thing is, though, when breast cancers are very fast growing and they're newly diagnosed, the triple negative breast cancers, I always tell women, the faster, the better when it's newly diagnosed, because those are the most responsive to chemotherapy. So it's very, very aggressive, which means fast growing. That's really a good thing in the beginning. Those are the ones that have inflamed the immune system the most. So the immune system's ready to go to get in there and cure. But the problem is if it becomes metastatic, it's not good that it's fast growing, because patients don't live very long.
Yeah. Wow. Good stuff, man. I've got a question here from who's just on the show. She was asking if you should take the COVID vaccine if you were triple negative and BRCA positive. And she also did the PARP inhibitor, so she was kind of throwing that into the mix as well. She wanted to ask if she was safe to take the COVID vaccine. I think during our talk, she was mostly concerned about being BRCA positive and that being an issue with the COVID vaccine.
No, we are telling all of our women, and to get the vaccine as soon as possible. And our national guidelines say that no matter where a woman is in her chemotherapy, let's say a woman has recently been diagnosed, let's say, with triple negative, or let's say she's on the PARP inhibitor, which I'll mention here in a second. Let's say she's on the PARP inhibitor trial and she's getting the PARP inhibitor. And there's some decrease of the immune system with PARP inhibitors and with chemotherapy, of course. Should she wait? Should she try to time the COVID vaccine until her counts have recovered and then get it? And our national guidelines say just go ahead and get it. We get obviously 2 injections, at least with the Pfizer and the Moderna. We're getting 2 injections. And those really are very, very strong immunostimulants, because the chances of being immune, very highly immune after even the first is 80+%. And the thing is that when women get chemotherapy and their blood counts drop, right, within a few days, the blood counts are on the way up again. And so they can those increasing blood cells can utilize the vaccine to become immune. So even though a woman might get vaccinated, when her blood counts are down, they're not down for long. And then they come back up again, and they can actually interface with the vaccine. Now, what we don't know is, we just don't know whether women in the middle of chemotherapy will have the same antibody levels against COVID, but also T cell. We get not only antibodies, we get T cell responses, lymphocyte responses against the COVID. And so we don't know whether they'll be as strong, but it's likely we're going to be getting boosters down the road against various variants and such. And it's very likely that women in the middle of chemotherapy will still get some immunity against COVID. And the most important thing is to try to avoid COVID, particularly during treatment, because thankfully, not because people with cancer tend to get worse COVID. That does not seem to be the case. It's just that you have to interrupt the treatment for 3-4 weeks. And that's obviously not what you want to do. You want to actually keep the treatment going. So we're really strongly encouraging women to get the vaccine whenever, at the first opportunity. So let me just mention the PARP inhibitor. This is we had seen a press release so far. We haven't actually seen the data, but there's a PARP inhibitor called olaparib. That's the generic, and the trade name is Lynparza. And there was a very, very important trial done called Olympia. Sounds like Courtney was part of the Olympia trial, which is wonderful.
I think that's what it was. Some of those names sound familiar. So yeah.
Awesome. And it was for women with newly diagnosed triple negative breast cancer, or actually they actually changed it to be able to enroll estrogen receptor positive patients as well that had inherited either a BRCA1 or a BRCA2 gene. And so the women finished up their standard chemotherapy. If they were ER positive, they were taking anti-estrogen therapy as well. And then they were randomized to take the year of Lynparza, olaparib, or not. I'm forgetting whether it was placebo-controlled, probably was placebo-controlled for 1 year to find out whether an additional year of treatment with the PARP inhibitor would improve outcome, meaning decrease the recurrence rate and decrease the death rate from BRCA1 or BRCA2 related breast cancer. And we got the press release that the trial is positive. So it worked. The PARP inhibitor worked. And so now they're waiting to do the final analysis. We should get the data very soon. Now, what is a PARP inhibitor? A PARP inhibitor is a pill, a daily pill. And in the context of having an inherited mutation in BRCA1 or BRCA2, the cancer cells do not repair their DNA very well at all. And then they become very dependent for DNA repair on a DNA repair enzyme protein, PARP. They need it. They need it because they don't have BRCA1 or BRCA2. And so when you inhibit another leg of the DNA repair, stool, you just knock the whole thing out. The cancer cell can't survive. It can't survive with loss of both BRCA1 and BRCA2 and the PARP enzyme. So highly synergistic, very powerful cell kill. So it's very exciting that this really will be very rapidly become a standard of care for women who have a breast cancer due to inheriting a BRCA1 or BRCA2 gene. So that's another advance, although we haven't seen the data yet, but we did get the press release very recently.
That's so cool. I'm sure she's going to be very excited to hear that. Yeah, Courtney was in that trial. She started that clinical trial back in 2016, 2015, 2016. And so she's been reporting in, and she's been doing great. She was stage 2, and she's doing fantastic. So that's a great question. So it sounds like for her, at least from what we know, the COVID vaccine would be smart for her to do. And of course, and I know that you're with me on this. And when I had my vaccination last weekend, of course, there's some stuff on there that says don't do it if these things. So be sure you read all the print. Like if you had an allergic reaction to other vaccines and stuff, they want to know about that. So be sure and read that print. But as far as having the vaccine, if you're a triple negative breast cancer survivor, BRCA positive, definitely sounds like the way to go. So that's good to know.
Really.
And coming up next, we're going to have Amy, and she actually threw a couple of questions in the bucket here too, Dr. O. She says, what role might corticosteroids play in cancer growth?
Mm-hmm. That's a really good question too, Amy. So the breast cancers, including triple negative breast cancer, do have receptors for the glucocorticoids. These are the steroids. We just call them steroids for short. The prednisone, dexamethasone, otherwise known as Decadron, et cetera. They do have receptors, and there's a lot of work that's been done by a very good scientist named Dr. Suzanne Konzen. And she has shown that the glucocorticoids can stimulate triple negative breast cancer growth in the laboratory, for example. Interestingly, glucocorticoids can kill ER positive breast cancers. There's a glucocorticoids, prednisone used to be part of breast cancer regimens. There was a
no
regimen.
Idea. Wow.
There was a regimen back in the 70s called the Cooper regimen. It was CMF, Cytoxan, methotrexate, 5-FU. We still use that today, along with vincristine and prednisone. So CMF VP, it saved a lot of lives. It cured a whole lot of ladies. They used to give it for a full year. And so prednisone, the corticosteroids can actually kill some of the ER positive breast cancers. It's complicated because some of the triple negative breast cancers, maybe around 20, maybe as high as 30%, have some androgen receptor. So they're a little bit more like estrogen receptor positive breast cancers than they are like the real fast growing immune stimulating basal breast cancer. So triple negative breast cancer is what we call quite heterogeneous. It's not uniform. It's multiple diseases in one bucket called triple negative breast cancer. And so we actually don't know whether glucocorticoids can stimulate, for example, the androgen receptor. The androgen is male hormones, testosterone, right? We women have a little bit of testosterone, and breast cancers, about 30% of the triple negatives have androgen receptors. And whether the glucocorticoids are a positive or a negative there, honestly, we really don't know. My own feeling about it is that we should use the glucocorticoids as sparingly as we can. We do use them on day one with, doxorubicin, adriamycin, and also with carboplatin, because both of those can cause a lot of nausea. And also carboplatin and also paclitaxel, Taxol, those two, Taxol carbo, they can cause infusion reactions, allergic type reactions. And if we get those, then it becomes not safe to treat the woman with this life-saving chemotherapy. So we do use the corticosteroids, usually dexamethasone, Decadron, on the day of treatment. And then for nauseating therapies like adriamycin, if you give carboplatin low dose weekly, it's really not nauseating. So you just have to give one dose to prevent an allergic reaction, before the infusion. But with adriamycin, all of our nausea regimens require a lower dose of the dexamethasone for 3-4 days after each treatment. Our cure rates are still, for stage 1, the cure rate's 90-95%. For stage 2, it's got to be 85-90%. For stage 3, it's 70%. So we still are having increasing cure rates, and importantly, we're seeing this improvement in outcome in the curative setting with the immune stimulants, the checkpoint inhibitors, as I was mentioning, and we still use steroids. And sometimes we have to use steroids because people have these, colitis or pneumonitis or, this autoimmune inflammation, and we have to stop the therapy and we have to give high doses of steroids for weeks. But what they've shown? They've shown that you do not lose your immune response against the cancer with the steroids. You see, these medicines, the Keytruda and the Tecentriq and others, have been around now for 5-7 years. They're approved for 20 different cancers. So there's vast experience. And there are many, many people who have gotten autoimmune reactions from these and need high dose steroids. So they know that that's safe to do, and people do not lose their immune response. So that's a different issue than Amy was asking about, what about glucocorticoids, about receptors? Is there any stimulation? And the truth is that there's some laboratory suggestion or some data actually, that there can be some decrease in effectiveness of chemotherapy, some growth stimulation. But honestly, we don't have any human data in that regard.
Wow. I would love to see like a chart from like the 70s to now with that cure rate that you were mentioning when you started talking about, 95% cure rate, stage 1, 85, whatever. As it went up, I was just like, wow, because that's, it used to be so scary, any kind of cancer diagnosis back in the day. And it's just really improved a lot thanks to people like yourself, Dr. O, out there fighting the good fight for this. And I've got another question here from Amy, but I think we may have kind of answered at the beginning because you were able to give us that big update on everything you're doing. But just to make sure, was any of the trials that you guys are doing right now, does that relate to metastatic triple negative breast cancer? She was curious about any effort to get new drugs approved as first lines of treatment for metastatic triple negative.
Yeah. Well, there's been another approval in the last year. The brand name is Trodelvy, and the generic name is sacituzumab. This is a very new very new and important therapy for triple negative breast cancer. It is an antibody. It's an antibody protein that's chemically attached to a very powerful chemotherapy drug called deruxtecan. And it's called SM38. SM38. It's a topoisomerase 1 inhibitor in the same sort of family as adriamycin, if you will, but it works very differently than any of the usual chemotherapies that we use for triple negative breast cancer. It's been approved for metastatic triple negative breast cancer late line. At third line, so with 2 prior treatments for metastatic triple negative breast cancer, so the third treatment or later. Very, very effective, a big improvement in overall survival. So as a result of that, it's now in combination in the first line setting with the checkpoint inhibitors. I think it's with Keytruda, but it could be Tecentriq, it could be both. But probably even more importantly is that it's being moved up now into the curative setting for women who get preoperative chemotherapy who still have residual disease. At surgery, when they go to surgery, there's still remaining cancer in their breast and or lymph nodes. Those women have a higher risk of recurrence. And the standard of care right now is 6 months of a chemotherapy pill, Xeloda, otherwise known as capecitabine. And in this trial, it's going to be a head-to-head comparison of the Trodelvy versus the Xeloda pills to move this very powerful agent up into the curative setting. So it's very, very useful to us now for women who have had prior treatment for metastatic triple negative breast cancer. I think it's going to be increasingly used even in the first line setting. Right now in the first line setting, I think what really people are trying to do is they're taking the checkpoint inhibitors, the Tecentriq and the Keytrudas mainly, but also durvalumab is another one from AstraZeneca, and also nivolumab from BMS. So there's probably 4 of them that are being developed in triple negative breast cancer in combination with chemotherapy, and then adding another agent to it. Let me give you an example. I've been fortunate to be able to participate with the development of a new drug for triple negative breast cancer, and it will be in the first line setting. It's going to be opening very soon. The name of the medicine is trilaciclib from a company called G1 Therapeutics. And it is intravenous and basically has, I'm going to say, kind of no toxicity. It's like very well tolerated. And it's given before gemcitabine carboplatin chemotherapy, the gem-carbo, very common chemotherapy. It's given before gem-carbo. And it's the goal of it is to increase the immune response against the cancer. So the gem-carbo really can also, it starts killing the cancer cells, and that can really activate the immune response against the cancer. But the trilaciclib can protect the immune system against the chemotherapy, but also can help the chemotherapy kill the cancer cells by getting rid of some DNA repair. And so the trial that's just starting is gemcitabine carboplatin with or without the trilaciclib. Now, the next step is going to be to add the checkpoint inhibitors, the Tecentriqs, the Keytrudas of the world, to the gem-carbo trilaciclib. But the first step is to do the gem-carbo trilaciclib. But that's one example of many, many examples looking to increase the immune killing effects against triple negative breast cancer in the first line setting in newly diagnosed patients. This is an area of particular interest to me because that's exactly what I'm studying, is how to make some of the cold tumors that are not the triple negative breast cancers, metastatic triple negative breast cancers that are not killed off by the immune system. They're cold. They don't have the immune cells that have infiltrated them. How to make them hot, how to make them seen by the immune system and hot with a lot of immune cells in there. And there's a number of trials. I'm doing a couple of them, but other investigators, Dr. Priyanka Sharma at the University of Kansas, has finished now enrollment in stage 1 at least. So hopefully it's going to look very positive. So she'll open it up and do more. But she it was giving cisplatin, the chemotherapy drug cisplatin, with the checkpoint inhibitor nivolumab, from Bristol Myers Squibb, along with an HDAC inhibitor. That is also it's a pill. It's called romidepsin, and it also can change the DNA in the cancer cells and stop DNA repair and increase the ability of the immune system to see the cancer cells. So it changes, it remodels the triple negative. And I sent her a couple of patients to go to Kansas and get on that clinical trial, and both patients have done well. They've had kind of very durable responses. Now we don't know yet for sure whether that's going to be better than our standard therapies, but that's the kind of thing that's being done. We've got to make more of these triple negative breast cancers immunogenic. That means seen and capable of being killed by the immune system. So that's a big, big, big area of research.
It's so cool that you guys all kind of talk and partner. All you triple negative breast cancer investigators. I liked it when you said other investigators work. And it's true. You guys are like investigators, and talking about all this stuff. And man, it's so fascinating. You clearly have a passion for this, Dr. O. One of the questions that we had here, and just to give everybody up to speed who may be just joining, this is Dr. Joyce O'Shaughnessy here with me today, and we were talking about triple negative breast cancer, which she does a lot of work in. That's basically your career. So Lynn has a question. She wanted to know why you chose breast cancer specifically as your field.
Well, as is so much in life, and I didn't know this when I was younger, but I learned this along the way. So much in life is serendipity. So much of life is just changing things up until you find the right thing, because it's very difficult to know in advance what the right thing for you is and what the right path for you is. Very difficult. So I finished training in internal medicine. I finished my training as a fellow in oncology. And quite honestly, I was at the National Cancer Institute, and I stayed there for some years doing, academic type medicine, but I wasn't really sure which direction I wanted to go in. So I was doing all different. I had many different jobs in the National Cancer Institute, from, clinical trial development, nationwide, to interaction with the FDA to work out some guidelines to speed up drug approvals. I did a bunch of different things at the National Cancer Institute. And then one day, what happened is that the breast cancer department at the National Cancer Institute, which I was just I was going over there to see some patients, one day a week to make sure I kept my clinical hand in, that group of people all moved down to Georgetown, because the head of the breast cancer section, Dr. Mark Lippman at the NCI, he became the cancer center director in Georgetown, which is in DC. And so then Dr. Ken Cowan, who was a friend of mine, took over the department. And he said, well, why don't you come on over and be the clinical breast cancer doctor, be the head clinical breast cancer doctor? I said, well, I like you, so why don't I go do that?
Yeah.
I'm like, oh, it was the best. It was the best. It was the best. So that's how I found it. But really and truly, I wasn't sure. I was trying all different kinds of things at the National Cancer Institute to see what the right fit was. I really didn't know in advance. So I think you've got to keep changing until the right thing comes along. But that's how it happened. I just loved it.
Yeah.
The combination of patient care and research together.
Yes, and you are just a master at that. As Amy Boyd will say here in a minute, you're the wizard. And in case you guys also missed it, Dr. O was my oncologist when I went through triple negative breast cancer back in 2010. I've been cancer-free for 10 years as of November. Thanks to you, my lifesaver, Dr. O. We have a few more questions here. I know we're a little over time. Are you okay to
I'm good. I'm fine, April. Fine.
Cool.
Yeah.
You just start throwing things at the camera when you're not. I've got a question here from Lisa, who's going to be coming up later in the show. She's going to be our last guest today. She says, is it necessary or beneficial to continue seeing your oncologist versus your primary care physician? Generally, my oncologist just orders lab work, quick breast exam, and asks me some questions. And I know, like for me, you had me stay coming to you for 8 years, and then you let me go. Some other women I've talked to have been released sooner and asked to stay on with their oncologist. So I think it's just kind of answering that question in general.
Yes. So for triple negative breast cancer in particular, because it's a very fast growing cancer, by 3 years, if a woman is still cancer free, she's got a 90% plus, maybe closer to 95% cure rate. By the time she's at 8 years, it truly is about 99%. There's the very rare triple negative breast cancer, one of the real slow growing variety, the very rare one that will recur after 8 years. And so I usually give women the option of following up with their primary care physician. Some women don't want to do it. They would much rather just come in and do a good exam, basically get some blood work. I get a chest x-ray once a year because triple negative breast cancer can recur in the lungs, and that's not on our national guidelines. Our national guidelines say do a careful history, do a careful physical exam, and follow up on anything, that's of concern. Have a low threshold, but I just get blood work and chest x-ray. Of course, if a woman has breast tissue, then of course you want 3-dimensional mammograms. If she's got a strong family history or a germline BRCA1 or 2 or other type of mutation, you want MRI. We talk about well woman care, et cetera. But usually by year 8, I must say, most women, when I start preparing them around, year 5 or so, most women are very happy to not come, back to the cancer center if they don't have to. Although, some women really do want to come back. Now, that's really different with estrogen receptor positive breast cancer, because unfortunately, with ER positive breast cancer, we can get recurrences at 10 years, 15 years, 20 years. Unfortunately, that one we can't, say that people are really cured. But I use the cure rate word. I use cure when women get to 5 years. They're really, really very likely to be cured. But stay with me till you're 8, and then we're going to declare total victory, is what I say. And I really hasn't had a problem yet with anything. Now, what do the primary care doctors do? Well, when we become post-menopausal, which unfortunately a lot of the treatments for breast cancer make young women post-menopausal, they stop menstruating. Well, then we have to watch our bone health. We have to watch our lipid health, cholesterol, triglycerides. We have to watch out if our weight will creep up after menopause. Our metabolism slows and women can become overweight. And so then we have to watch out for things like, elevated glucose levels, fatty liver. There's a bunch of things that happen to us as we get older. And then as we get older, over the age of, 50, there's, some of the shingles vaccines, et cetera. So there's a bunch of things in the well woman care department that we really do want to be taking care of, after we're menopausal. And so for premenopausal women, most premenopausal women still choose to be followed up by their, OBGYN doctors or gynecologists. And that's great because the gynecologists function as primary care physicians and, do pelvic examinations, pap smears, et cetera. And so that's basically it. It's just that, people don't really need to see the cancer doctor, once they've, passed the 8-year mark in triple negative breast cancer. But they do need, I do say, if women still have breast tissue, I do encourage them to continue to see their breast surgeon. Many women continue to see their breast surgeon, get really good examinations. And also the breast surgeons will they'll look themselves, the mammograms, the ultrasounds, the MRIs, if those are necessary. But some women haven't seen their breast surgeon. Their medical oncologist was ordering those things and doing a good breast exam, et cetera. That's okay. That's okay as long as they continue to get the tests that they need. And now there are these survivorship forms that are very useful, and these can be filled out. Some practices really are very good at this. It's really encouraged by ASCO to do these survivorship forms, and they're basically blueprints. They're blueprints for what it is the woman needs going forward. What I do is I just I dictate that, and the woman knows what she needs, and I send it to her primary care physician so everybody knows what she needs going forward. Because fortunately, thank God, the vast majority of women with breast cancer do well, and and then we need their primary care physicians to really be a very important part of their care.
That's a great answer. And you covered the whole realm of situations too, which is so helpful to our viewership. Dr. O, I really appreciate that answer. Very good. Lisa says she has another question here, and my apologies. She was actually on earlier tonight. She says, I've heard that implants must be replaced about every 10 years. Is this accurate? I know you're an oncologist, so you're not a surgeon, but I wonder if you know the answer to that question.
Yeah, I do, because it comes up all the time. It used to be thought that they should be changed every 10 years, but actually, thankfully, that's no longer considered the case. It's now considered, if it ain't broke, don't fix it. So if they're fine and there's not, sometimes with, prior radiation, for example, they'll develop a lot of fibrosis, scar tissue around them. They get very tight. They can ride up, for example, ride up higher than the one that didn't have radiation or the normal breast. And so women will want to get them changed out. Or sometimes they'll deflate. Or they'll, basically move or what have you. Relatively uncommon, thankfully. Women really don't need to have them replaced. There are these textured implants that very rarely cause anaplastic lymphoma. And this is a very rare phenomenon where the texturing, the chemical texturing basically acts as an immune stimulant. And it kind of stimulates over the years the lymphocytes, and very rarely they can turn into lymphoma. Fortunately, if now that we have a higher index of suspicion, any time a woman suddenly, it's usually some years down the road, develops fluid. If she were to develop like a pocket of fluid, all of a sudden there's, instead of just being the normal implant, there's now fluid. Or discoloration, redness, purpley, purple violet color, that needs an MRI. That needs an MRI to see if there's any thickening in there. And when in doubt, there should just be removal, of the implant, because if there is any lymphoma there, it's confined, and just removing the implant and removing the tissue around that implant is curative in the vast majority of the time. Very rare for this to spread any place and become a real live lymphoma, that requires chemotherapy. It's not zero, but it's exceedingly rare. But this lymphoma around the textured implant is exceedingly rare. I've been doing this 35 years, seen one case. I mean, this is so rare. So the plastic surgeons do not recommend removing the textured implants and putting in the non-textured. The companies who make the textured implants, I think they're actually covering the cost, and they'll cover the cost to have them replaced. So some women want to do it, and that's obviously their prerogative, but it's not considered necessary, because again, we kind of know what to look for, and it's so incredibly rare. And so you don't want to, do surgery that you don't have to do, because with every surgery, there's a slight possibility of a complication. So anyway, that's the deal on implants there.
That's really good to know. It's funny because, I didn't have implants. And so a lot of this stuff is really new to me to learn about. And so when folks ask this question, I'm like, oh, I thought it was like one and done. But it's good to know that now it's not like you have to do it at certain frequency. It's like you can wait longer and longer. That's really great.
As long as they're not bothering you. Yep. As long as they're fine. Yep.
We've got another question here from Courtney. This is another Courtney. She asks, is it normal to have chemo brain for years after chemo?
No, Courtney, it's not. And this has been studied. This is something I actually did some work on, a long time ago, about 20 years ago. I was, doing some trials on this. And what they've shown is that when women are getting chemotherapy, and particularly methotrexate and 5-FU, the CMF regimen, not so much the AC and paclitaxel, Taxol, Taxotere regimens, there is a chemo fog. There's clearly a week or 10 days after the chemotherapy where women, it's much more difficult to multitask. The short-term memory is a little bit, challenged, but just a little fuzzy, just more difficult to just, handle all the 50 million things that women handle every day. That's chemo fog. And then, of course, it's exacerbated by the fact that it can be difficult to sleep during chemotherapy. Steroids, changing hormonal situation, coming on with cessation of, stopping of menstrual periods, hot flashes, difficulty sleeping. So it's multifactorial, but what they've shown, thank God, from a chemotherapy standpoint is that in women who have had impairment, they really did have decreased cognitive function during chemotherapy, the chemo fog. If you do studies on them 2 years after diagnosis and compare them to age-matched controls, no different. Thank goodness, no different. There's a investigator that's been in this field forever, Timothy Ahles, Ahles. If you want to look at some of his work. And then there's a really good group in the Netherlands as well that has been at this a long, long time. So they have a long-term follow-up now, way beyond 2 years even, that show that women's cognition, their brains are as good as normal. Now, having said that, there's no question that back when we were doing bone marrow transplantation, thank goodness we don't do those anymore, in young women who got mega dose chemotherapy, they went into early menopause. I have, unfortunately, I've met such women. They weren't my patients, but I've met such women that, had definite impairment. So that, for example, they were, this one woman I remember, she was, she worked in a photography shop, and it was a very detailed, very complex. Every single, part of it was different, and, all the various options, and talking to customers. She couldn't do the job, anymore. Women who were accountants, very complex mathematics, et cetera, couldn't do it anymore. But this is in the context now of bone marrow transplantation. The thing is that what happens, however, is that when women go from premenopause to postmenopause with chemotherapy very precipitously, kind of like, within months, they go into a deep postmenopause, then, women, they don't sleep really well at all. And that's the first thing I ask women when they tell me they're feeling fuzzy headed, et cetera. You might have chemo brain. I say, first thing I say, how well are you sleeping? And so most of them say not well. I'm like, okay, we got to fix that, because I'll tell you, once you're postmenopausal, you got to sleep. If you don't sleep really well, our brains don't work, the way we need them to work. It's much more difficult. Exercise, super important as well. But so the answer is, thankfully, we don't think that there's long-term cognitive brain injury issues from today's modern chemotherapy.
I'm so glad that you spelled that out, because I even struggle with that today, thinking, oh, I still have chemo brain, but you hit the nail on the head. I don't get enough sleep most of the time. I'm looking down at my Fitbit, and it says, 5.5 hours or something, and I need to be getting more sleep. And people don't understand how important that is. We talk about health all the time, and you always fixate on exercise and food, but you don't think much about the sleeping aspect and how important that is. That should be paired right in with the others for sure. And I'm just going to hit you with a couple of more questions, because I know we're running way over. I've got a question from Courtney again, another Courtney. She says, sometimes I feel like I am having hearing issues. Can chemo cause any hearing issues? I think she has had chemo more recently.
So cisplatin, which isn't used very much, usually it's used for metastatic disease. Cisplatin can cause hearing impairment. But other than that, no. And so the thing is, however, that the cyclophosphamide, the Cytoxan, can cause sinus inflammation, and that can back up into your ears. And so you can get fluid and inflammation in the inner ears. So I would have the ear, nose, and throat doc take a look at that and see if there's fluid in your ears from inflammation, from cyclophosphamide sinus inflammation. But other than that, thankfully, there is no injury to the neurons and the inner ear, or our hearing facility with the chemotherapy. Thank goodness.
That's good. It's funny, Dr. O. I find that we all want to blame anything on chemo. Well, I bet it's from that chemo, that's where my hearing problems come from and everything. I'm going to take one last question here. And this is from, I think her name is Tana, Tana, from Massachusetts. She says, I'm stage 4 triple negative breast cancer survivor. I'm on trial I'm going to screw up these words, Dr. O, but on a trial of Trodelvy and talazoparib, okay,
Talazoparib, yes, yes.
PARP inhibitor. So far, I'm stable with 30% shrinkage and considered stable. How many metastatic TNBC patients can get to remission? And once there, what are the stats? Sorry, I'm having to. Looks like it might have been pasted wrong. What are the stats of getting it again? The same? Is it the same as other breast cancer survivors?
So yeah, that's a very, very good trial that's going on. It makes a lot of sense, to put the talazoparib, which is one of the PARP inhibitors, put that together with the Trodelvy. We're really hoping that's going to make another advance, to be able to put those two together. So, the name of the game is staying in remission. It's great that there's already been a 30% reduction in the cancer. And the key is to try to continue on the therapy, even though there likely will over time need to be dose reduction in the Trodelvy and also in the talazoparib, and that's okay. And the maintenance phase, that's the real key, is you want to maintain. This is the situation that I've seen, and I've been so blessed, and we all have it, who take care of patients a long time. There are triple negative patients who, they continue to have benefit, and sometimes if you can just maintain it, there are some women where the cancer will simply not grow back. Unfortunately, these are rare, but not zero. And so this is why we do research. We don't know what's going to be the outcome of Trodelvy and talazoparib. We hope it's a home run. We don't know whether 10-20% of women may stay in a long-term remission. That's why we do research. We need these next advances. So unfortunately, Tana, most women, unfortunately, the cancer will become resistant to those two drugs you're on over time. Most women, but they'll have to go on to something else. But we don't know. We don't know whether there'll be a group of patients who are able to stay on for years. We certainly hope and pray that will be the case. And people like you that are getting in there and working with the doctors and the research coordinators and really working to stay on it and communicate what are the side effects so that they can tweak the doses and make it right for you so that you can stay on it for as long as you're benefiting. That's the key, because that's where we then have somebody do well, is when they can stay on something for a long, long time that's helping them. So I certainly hope that's going to happen to you.
Awesome. Thank you so much for that. And Dr. O, I'm going to end with the questions, but except for that, I want you to do the thing that I always ask you to do at the end of each of our talks, is to give that spiel real quick on what the best things that you can do for yourself to reduce your risk of recurrence or reduce your risk of breast cancer.
So, there's a very important study called the Harvard Nurses Health Study, where, our tax dollars through the NIH have been following tens of thousands of nurses for decades for a variety of health issues. And they're very good historians. The nurses are very, very good filling out all these forms twice a year. And there's thousands and thousands of these women who have had breast cancer, been followed for a long, long time. And a paper that was published, oh gosh, it's got to be 15, 18 years ago now, showed that breast cancer survivors who walked a moderate pace walking 3 hours a week had a 50% less chance of dying of breast cancer. I say to my women, that's better than any medicine I have. I don't have anything that's going to get you down 50%. That's huge, basically.
It's amazing. I mean, every time you say this, it's just unbelievable. The kind of control we can have on our own health just by walking 30 minutes a day.
Right.
50%.
Right.
Yeah.
50%. And, it can be Zumba, it can be whatever. It just has to be a moderate pace, The other thing is that for triple negative breast cancer, there's the WINS trial, the Women's Interventional Nutrition Study, where triple negative breast cancer patients, in particular ER negative patients, had a huge benefit from a substantial reduction in their fat intake. Now, these women also lost weight because they lost not that much. They lost about 6 to 8 pounds. But when you eat less fat, it was quite a low fat diet, quite a low fat diet. I always tell women it's a difficult diet to sustain. It's but I tell them to at least try to avoid the fats that we know are really poor for us. It's basically all of the foods that are processed. All the processed foods have fats in them that are very, very poor, but natural fats that are in some of our vegetables, our fruits, avocados, nuts, for example, olives, etc. I think in moderation, I think is good, but a low fat diet. And I think there's some very toxic fats that are in the processed foods, and they show in cell lines. In cell lines, they can actually stimulate triple negative breast cancer patients. So I think for triple negative in particular, a low fat diet. For ER positive breast cancer, what they've shown is that once a woman is a breast cancer survivor, avoiding weight gain, particularly 10% or more of body weight, it really increases growth factors. I think that's important for all breast cancer survivors. I think all of us should be trying to get down to in the normal weight range and trying to increase muscle mass, because muscle mass helps the metabolism. Muscle mass lowers insulin. And I think we should all be trying to lose weight. If somebody's overweight or obese, they should be trying to lose weight because it lowers all growth factors and insulin. It stimulates the immune system. But I think avoiding substantial weight gain, and that's defined as 10% or more. There are a couple of clinical trials going on focused specifically on weight loss in women who are breast cancer survivors, and exercise. And we don't know the answer yet. We don't know whether a 10% weight loss in someone who's overweight or obese, just 10%, will improve their outcome from breast cancer. In talking to the gurus who are running these trials, they expect that will be the outcome of the trials, but we don't know that for a fact. But we do know that weight gain, especially postmenopausal weight gain in the ER positive context, is to be avoided. And then lastly, the one that I think is really good, I only talk about things that have very strong data. I don't want to tell women and recommend things that don't have very strong data, because women need to focus their efforts where it's going to make a difference for them. The last one I always talk about is alcohol. It's unfortunately clear that drinking more than one drink a day, or even up to one drink a day, can increase the risk of getting breast cancer, can increase the risk of getting a second breast cancer, and can increase breast cancer recurrence. So I always tell women, drink less than one drink a day. I always say 3 to 4 a week, 3 to 5 a week, 4 or 5 a week. That's safe. I always say vacations, that's a little different. We may have a little more, but holidays, but week to week to week, no more than 3, 4 drinks a week is really, really safe. 1 or 2 drinks every single day is, too much. And so that's another thing that's very, very well proven in my read of the literature.
That's awesome. Those are the 3 things that I always continue to share, Dr. O. And every time we have a recording of you saying this, and all my groups where they're asking this question, I send them straight to the video, tell them the exact point on the video where you're talking about it, because I feel like it is so important. Like you said, you can make the biggest difference with those things that you have such great data from. So it's so powerful. Dr. O, I cannot thank you enough again for another year joining us here at the Triple Negative Breast Cancer broadcast. It means the world to me. It's so important to everyone watching, all the triple negative breast cancer survivors and other folks out there watching today. So very helpful. I can't thank you enough, and I can't wait to have you on again and chat some more.
Every year. Thank you so much, April. Thanks for all you're doing with your foundation, all the funding, and the funding you've given for my breast cancer, my triple negative breast cancer trials that are going on right now.
Absolutely.
Thank you very, very much for helping make them a reality, April. And thanks to everybody. Hang in there. We're all hanging in there. We're all hanging in there, doing the very, very best we can to move the field forward. Good night, everybody.
Amen. Thank you so much, Dr. O. Have a good evening.
Bye, everybody. Bye-bye now.
All right, everybody, give it up for Dr. Joyce O'Shaughnessy. She's a rock star, man. The rock star. Goodness gracious.